My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I'm also the Associate Chair for Multidisciplinary Oncology in the Department of Surgery, and I am the Director of the BPREP program. BPREP is our high-risk program for women who are concerned about their risk of developing breast cancer. When we're discussing surgical options for breast cancer patients, they really fall into two primary categories: the option of keeping the breast or breast conservation, and the option of removing the breast or mastectomy. Breast conservation is really a two-part deal. It consists of lumpectomy with whole breast radiotherapy. When a lumpectomy is performed, it's important that the surgeon obtain negative margins. That means that the tumor is in the center of the specimen of tissue that's removed, and there's a nice rim of normal tissue around the edge. And that edge is what we call our margin. Negative margins are important because we know that women who do not obtain negative margins have higher risk of local recurrence with breast conserving treatment. The use of whole breast radiotherapy in breast conserving treatment is to decrease that risk of local recurrence. And we know that radiotherapy is very effective in decreasing local recurrence from multiple randomized controlled trials demonstrating that without radiotherapy, risks of local recurrence are much higher. So I tell my patients that when we keep the breast, lumpectomy plus radiation therapy is a package deal. Now, the alternative, removing the breast or mastectomy, is also a very good treatment option. And in some women, that is their only treatment option. The tumor may be too big to remove with the lumpectomy, or they may have skin involvement and we may need to do a mastectomy, such as an inflammatory breast cancer. But when a woman has equal options, when her surgeon says we can either do breast conservation and keep your breast, or we can remove your breast, the important point there is to remember that the two treatment options are equal when it comes to survival from breast cancer, as well as risk of recurrence of breast cancer. So it's often thought that bigger surgery must be better, that removing the breast would result in lower rates of recurrence. And that in fact is not true. And it's not true today because of the effective systemic therapies that we offer and because of how much our understanding of the biology of breast cancer has advanced. So now that we know that women who have hormone receptor positive disease benefit from hormonal therapy, not only in reducing risk of distant recurrence, but as well as in reducing risk of local recurrence, as well as women who have HER2 positive disease benefit from anti-HER2 therapy, again, not only in reducing risk of distant recurrence, but also in reducing risk of local recurrence. So when it comes to the surgical treatment options, we really want to help our patients understand that if you are a candidate for breast conservation therapy, if your surgeon says, yes, I think I can remove the tumor with a clear margin, and then we will treat you with whole breast radiotherapy, that is an excellent treatment outcome. Excellent treatment option, and is associated with outcomes that are absolutely equal and just as good as removing the breast. And of course, breast conservation is a much smaller operation. It's typically outpatient surgery, and patients return to their normal activities much sooner having undergone that operation than having undergone a mastectomy. Now, in some patients, a lumpectomy and whole breast radiotherapy is just not a feasible option, though. The most common group of women where we really do not recommend breast conservation is those women who present to us with inflammatory breast cancer. Inflammatory breast cancer is a special subtype of breast cancer that presents as a diffuse involvement of the breast tissue, as well as the overlying skin of the breast, with cancer cells being identified in the what we call dermal lymphatics. The breast actually does look inflamed, and often this diagnosis can be confused with an infection because the breast really does look red and inflamed and swollen. But inflammatory breast cancer is indeed a specific clinical diagnosis, and women who present with inflammatory breast cancer should always receive what we call multimodality therapy. Chemotherapy is always the first step in the treatment, followed by mastectomy, plus removal of the axillary lymph nodes. We call that a modified radical mastectomy, and then followed by comprehensive radiation to the chest wall. So that is the one group of patients where we do not discuss the option of breast conservation. We really rely on mastectomy as the treatment for inflammatory breast cancer.